Good afternoon, everyone. Please stand by. We'll get started with the webinar in just a couple minutes.
Hello.
Hi, Tina. Hello, all. We'll get started in just a
Hello.
few minutes. Good afternoon, everyone. Thank you so much for joining us today for our first UDS 2021 Support Series webinar. We are going to be recording this webinar so we can have it accessible to you anytime ongoing. And we hope that you will share this with your colleagues as well. Today, we have Tina Agarwal, clinical informaticist at Alliance Chicago, and she will be reviewing with us the UDS 2021 clinical workflows and data. So thank you so much, Tina. I'm going to hand it over to you.
Perfect. Thank you so much, Angela. And good afternoon, everyone. As Angela mentioned, my name is Tina Agarwal, and I am the clinical informaticist at Alliance Chicago. We want to thank you so much for joining our webinar today on UDS 2021 clinical workflows and data. Today we'll be going over the changes in the UDS 2021 reporting period, while also providing a general overview of our processes and an EHR agnostic lens. So just looking at a couple of different EHRs as well. We'll begin with some general tips and then dive into specific measures and examples. So that'll be kind of the path we'll be taking today. So when it comes to UDS reporting, there's certain steps that should be followed to get the best outcome. These are things we've learned over time, with going through this for the past, how many years, but wanted to go through a couple main components. So the first thing is the EMR setup. So the electronic medical record setup, it's important to work with your vendors to ensure the systems are updated with required specifications. So any kind of back-end setup, you want to make sure that all that is done based on your specific vendor. The second main component when it comes to UDS reporting is workflows. So we need to implement certain workflows in order to get the specific data we need for the reporting period. Data doesn't get to the reporting period without enacting workflows for us to enter the data in. So that is a big key component to kick off kind of collecting all that data, making sure that we're working on specific workflows within our practices. The third element here is data. So once those workflows are implemented and users are utilizing that, data elements and structured data are captured based on those workflows. And then we use that information to kind of feed these UDS reports based off of the measures that HRSA has presented. That leads us to this last section here where it says due February 15th, 2022. So once we get all our data, we want to make sure we analyze the data, get some aggregate data on patients who are compliant and non-compliant with the measure criteria, and reviewing all that information and going through any questions that may be present before the submission due date, which again is February 15th, 2022. So again, EMR setup, workflow, data, and the due date. Oh, I'm sorry. Someone have a question?
Do they have any little 4-year-old ghost costumes there?
I think someone just wasn't on mute. I've muted lines.
Thanks, okay,
Tina.
sorry.
Please
just wanted
go
to make
ahead.
sure I wasn't. Okay, perfect. So EMR setup, workflow, data, and then obviously the due date are kind of main components for the kind of reporting period. The UDS 2021 reporting period goes from January 1st, 2021 through December 31st, 2021. So an overview of some of the EHRs that we work with or have some experience with. So we here at Alliance Chicago, most of our network uses Athena Practice, formerly known as Centricity Practice Solutions. There's some on Athena One, and then we also have some folks that we're connected with that use eClinicalWorks, NextGen, our partners at Health Choice Network, Greenway Health, Intergy, and then a lot of these EHRs have Visolutions plugins. So we have a lot of different EHRs that we've had experience with from our network and from other folks close to us. So we wanted to kind of go over, when we get to the specific changes for UDS 2021, we're going to primarily focus on Athena Practice, which is what we have the most experience with, but we'll highlight, a few screenshots from other EHRs as well. So one of the main things with, depending on which vendor, which platform is being used, we want to make sure the back end setup is done for the specific vendors, and we want to point the various users to areas of importance within the EHR itself. So, as we know, an electronic health record is pretty much the same concept. It just may look different or maybe set up differently based off of these different platforms. So it's important to just kind of get acclimated to the areas of importance and knowing what specific setup may need to be done in the back end. So those are the EHRs that we kind of have some familiarity with. We also have some specific platforms that are just used for reporting. So there's Arcadia Azura and then Health Catalyst. So those are some platforms we're familiar with that, again, are just used to kind of report that data. So there are general tips on what practices should be doing to get the best outcomes with UDS reporting. As I said before, we've kind of come to these tips with our own growth and experiences over the past couple years. So I'm going to kind of go through at a high level some general tips, and then we'll kind of do a deeper dive on the next slide here. But the first thing that's important is to review the Program Assistance Letter, or PAL, that HRSA puts out that kind of gives a preview of any changes that may be occurring for the current reporting year. And then it's also very important to review the actual UDS manual itself once it's released, to kind of gauge what changes may be, overviews. They're pretty good at calling out, any kind of main changes. So it's good to kind of review that and, kind of be prepared for what's coming for the 2021 reporting period. Following reviewing the manual, you want to look at the measures that are different for the current reporting year, specifically to see, what has changed from reporting year, 2020 to 2021, and see what workflows may need to be changed, what changes may need to be done to the reports, and kind of, again, proceed and see how you can make those changes. So when it comes to reviewing new info and clinical workflows, we make sure that we review the measure change and see how it affects the report logic. We have a user-centered approach that focuses on usability and workflows, and we use that to help guide and inform any changes that we may make in the clinical content. So we're really focused on, when we're reviewing these changes and any new information on clinical workflows, we want to kind of see how the clinician would interact with it and kind of keep things in that user-centered approach. If there's an update that tends to happen, where something's not known until about halfway through the year, our process is we go back and we review any downstream effects, and we make any updates to the reports and communicate things accordingly, whether that means we are just communicating out a report change, or if we're communicating out any kind of clinical content updates. A perfect example that I like to use to kind of put this into a perspective is last year with the COVID-19 pandemic, the telehealth guidance was not released until almost towards the end of the year. So all these months of the reporting period had gone by, and at the end, we were then kind of getting some more information on telehealth guidance and, what measures, will count a telehealth visit versus just an in-person visit. So again, that's an example that we had last year where we did not know about that till about halfway through the reporting year. So we, reviewed everything internally. We made any necessary changes we needed to the reports, and we communicated out any change that we made to our network through various different, meetings and communication, emails, and everything. So that's kind of our process for if something changes and if something changes midway through the reporting period. Another important thing or structure I wanted to go over is our wraparound support that we provide. So we have an internal work group that consists of various different groups, such as leadership, our data team, informatics, practice transformation. We have a lot of different groups at Alliance Chicago that ends up being a cross-team collaboration approach. And we use that platform to kind of review things and disseminate information to various different people based off of the connections we have. We provide wraparound support in the form of like a webinar. We perform wraparound support in this form. We have a lot of documents that we have on our Alliance Chicago Community Loop, which I'll go through later. But we have a lot of different things that we try to make accessible to the network, to make things kind of as easy as possible and to provide the most guidance that we can, because we do know, the manual is one thing, but translation is key. So we do believe that wraparound support is a big part of our focus when we dive into UDS land. So some recommendations that we want to provide to help centers that want to improve UDS numbers. This is kind of similar to the previous slide, but again, just going in a little bit deeper. So again, setting up the EHR based on workflows is going to be a big thing to get started with. Second, reviewing data early. We're big advocates on reviewing data early because you don't want to put yourself in a position where, you're reviewing it, right in February when the reports are due, 2 weeks later. It's an important process to kind of review things early enough to catch any changes or anything that, may be beneficial to the health center itself. When you see this agile methodology, it's just something we here at Alliance Chicago use a lot with various different, projects that we use. But when it comes to, UDS overall, we do kind of keep this methodology solid. So there is a discovery and plan period, and how that translates into UDS for us is we review the PAL, we review the manual, we attend any webinars HRSA may be coming out with to get some more information, and then we review the electronic clinical quality measures, the ECQMs, and try to get a lot of those data specifications. So that's kind of the discovery and plan mode where we're just kind of gathering all the information that we can. The next step for design, this is kind of, we're going to use this in the sense of we have something called the data request form. That's essentially just translating what the UDS manual has into a format that we use here at Alliance Chicago. Our data team uses those Excel spreadsheets to kind of program the reports. So in the design period, we would draft out any changes to those data request forms. And then we would also design any content updates that may be needed as a result of changes in clinical workflow. So designing is kind of just, laying things out in a more tangible manner on what's, forthcoming. When we get to the development, this would be the stage where the data team's actually creating reports. And if we're talking about any content updates, this would be the actual programming related to the actual content. So development's actually, getting your hands dirty and going into the changes here. And then testing is another part of this agile method, and testing primarily in our UDS world here is data validation. So once the reports are created, we go through a rigorous data validation that we do internally, where we're reviewing a lot of different health centers' data for various measures, and we're looking at, compliant and non-compliant reports. So data validation is probably one of the most important aspects that we work on to kind of see if, what we are creating in the reports is truly reflecting what the UDS measures are asking for. Finally, we have deployment. So deployment or release, once data validation is passing and, we are done with our due diligence there, we release reports to production. So that's kind of the end of the cycle, but the last part is feedback. So as usual, we go through these important steps to kind of implement whatever changes need to be made to report or our clinical content. But we also make changes according to feedback that we may receive from health centers, and we're always here to provide support to the network on any questions. So there is that, time period where after we roll all this out, but there may be some lingering questions or some clarifications that need to be made. So again, like we at Alliance use an agile methodology pretty often, but we can kind of see it very clearly when we work on our UDS. When our year begins and we start kind of diving into it, we kind of go through these steps, and we found that if you want to kind of improve your numbers, kind of going through the same process may be helpful, but just wanted to really emphasize reviewing the data early and reviewing the changes early enough is kind of one of the things that can be really helpful. So remaining agenda. So, now that we've covered our background on general UDS housekeeping and, some tips that we wanted to share, I'll be covering measures that have changes for the 2021 reporting period. Although I will not be showing all of the different platforms that I had mentioned for the EHRs, we have a lot of screenshots and workflows that are focused on Athena Practice that we wanted to share. And then I also have some screenshots from NextGen. So again, we're not going to be going through all the different platforms, but focus primarily on Athena Practice. So what's left is reviewing the changes from Table 6B, cervical cancer and tobacco use, reviewing COVID-19 related changes, reviewing telehealth guideline changes, and then just kind of going over resources. So we'll use the rest of the time to go over those. So cervical cancer is Table 6B, Section D. Just an update of the summary. The numerator was revised to align with updated clinical recommendations. So it's looking now for patients aged 30 years and older. It permits HPV testing alone every 5 years. It updated the description and removes the co-testing that was once there for the previous reporting year. So essentially that's the biggest change. And you can see here the comparison between 2020 and 2021. So yeah, looking at HPV testing for those patients in that age range, or looking to cervical cytology for those patients in that age range. So that's kind of a summary of what is going on with the cervical cancer screening measure. So our workflows that we've implemented here at Align Chicago and using Athena Practice, we have a quality of care checklist that kind of helps guidance for the numerator criteria. We have a lot of clinical decision support embedded into our content, and we have flow sheets to make things more easily visible. So kind of going into some screenshots here. In the top here, we have screenshots of what our cancer screening form looks like. So you can see here that you have the ability to document results, put any comments in, but mainly the results is what's going to be important. Our cancer screening form is based off of USPSTF guidelines. So, it's not looking at only UDS stuff. It's actually primarily built off of USPSTF guidelines. But I wanted to show this screenshot just to kind of show a visual of, having content in a workflow that enables you to document cervical cytology and or HPV results. So I just wanted to provide a visual of that. We do have some clinical decision support that is going to tell you if something's due or not due. And you could see here in my example, a patient got a pap smear and they've met the protocol. So just wanted to show you a visual of that. Moving down here, we actually created maybe about 2 years ago, or 2 to 3 years ago, we revamped a content item, which we call the quality of care checklist. And it primarily surfaces around all things that we're able to program related to UDS. So you can see here that you'll see Section D, cervical cancer screening. So this will show you, denominator and numerator information. It'll take you to that blue button that says cancer screening. If you click on that, it takes you to the content itself. We have a section for exclusions. If someone was in hospice care or had a hysterectomy or anything, being able to document that. And then we have these help texts that kind of go through specific denominator detail and numerator detail. But you could see that this patient, the numerator says yes in green, and they've met the numerator then for this cervical cancer screening measure. A pap smear was done within 3 years for this age range, and you'll see the yes in green. So we do encourage our health centers to add this form into their encounter setup. So then in common workflows when they're seeing patients, that they have this easily available to be able to, at a quick glance, kind of see, I'm seeing my patient today, what have they met, what haven't they met? So we've gotten a lot of feedback from our clinical health centers in the past of this being really useful. So yeah, we update this every year based off of any changes that UDS is presenting. But again, at a quick glance, this is a content item specifically meant for UDS. And then all the way here where it says flow sheet, this is just one of our other content items we have where, we have special flow sheets where you can see any kind of structured data being captured. And we have one called Alliance Cancer Screening Form. All of these data elements are linked to what we call observation terms. And you could easily see here a pap smear was done, and here's the result. So this is another way to kind of view things in a different manner. So we have lots of different types of content, but those are kind of some of the workflows that we have here with the Athena Practice platform. Moving over, I do have an example here. These are some screenshots from the NextGen platform, and you can see that users can select testing and document PAP or PAP HCV test performed, and you can document the date it was done and the results. So again, similar to what we just went through with Athena Practice, that just visually looks different. But the main concept with this measure is documenting that test result and knowing the date it was done. You could see here that I was talking about how we use kind of those observation terms in Athena Practice to collect that data. You'll see here with NextGen, kind of in their setup, that they have the list of values for the numerator, these specific LOINC codes for HCV tests and PAP tests. So again, the setup includes these LOINC codes, which help meet the criteria of that numerator testing. So just wanted to present this NextGen platform example. Continuing on, we have tobacco use, screening and cessation intervention, which is Table 6B, Section G. The change with that is that essentially it has revised timeframes for the numerator. So in 2020, it was looking at patients being screened at least once within 24 months, and now in 2021, that time frame has been shortened to 12 months. So that's the main change that occurred with this measure. It essentially revised timing associated with performing a tobacco cessation intervention in the numerator. So kind of the same setup for our workflows here in Athena Practice. Two main workflows that I feel like we've incorporated. So we have, encounter setups to have the initial intake in our common workflows, and that's a specific content item that I'll show you a screenshot of. That really, allows you to screen a patient for tobacco use, and it's one of the more common methods. And then we also have that quality of care checklist, clinical decision support for the numerator criteria, also built for this tobacco measure. So looking at our screenshots here. So I'll start with the quality of care checklist. As we mentioned, there is that kind of clinical decision support that tells you what's needed for your patient. So this first screenshot at the top, this patient has not been screened for tobacco use.
Sorry, not Mara. Tiffany?
This patient has not been screened for tobacco use, so you'll see that the numerator says no need screening. So we try to make it intuitive to really tell you what's needed for a patient at a quick glance. Now, if you look at the second screenshot here, this is just another example of how specific this form gets. So if your patient was screened for tobacco and they are a positive user, the measure states that they need to have some kind of intervention, counseling follow-up. So you'll notice here that if the patient was screened for tobacco use and it was positive, but they weren't counseled, you'll see that the numerator now changes to no needs follow-up. So it's very user-friendly in the sense of providing you with that clinical decision support on what's actually needed for this patient. We have, again, the jump buttons to common forms where this information can be documented. We have our structured data here to capture if someone was advised to quit or if any kind of follow-up counseling was provided. So we do have that built here in that quality of care checklist. The bottom screenshot here is just a visual of our initial intake form that we've created in Athena Practice. It's one of the main places that tobacco screening tends to be documented, and it is pretty common in a lot of the encounter setups. So that's a recommendation we provide to our users as well, to make sure that these forms that are going to be very beneficial in improving UDS numbers and workflows, to make sure those are added in to common encounters to help promote that workflow. So those are the Table 6B clinical measures that have changed for 2021. COVID-19, as you guys may all know, it's ever changing, and for 2021, there is a new line added to Table 6A, which is just a collection of codes. So it's looking now at the number of visits where a vaccine is administered to a patient. So we have that structured data now here where we're looking at the COVID-19 vaccinations. So when it comes to reviewing this COVID-19, updates and changes, we first wanted to review workflows related to COVID-19 vaccination. As we know, in the pandemic, things are happening at a rapid pace. So just kind of seeing what our health centers were doing at that time when vaccinations were available, and how they were documenting it, and just making sure we understood the full picture to better know how we can get those vaccines to count for this UDS line. And then after kind of reviewing those workflows internally, another part of our process is reaching out to HRSA to clarify any questions that we may have. So when it comes to COVID-19 specifically, Table 6A, the definition of that looks at CPT and HCPCS codes alone. So what we found out was many health centers were rapidly responding to the COVID-19 vaccine effort and just charting the immunizations without having the CPT HCPCS code set up. Again, this is early on in the pandemic when things are just happening very rapidly. So once we kind of found out that information, if we just went off the UDS definition alone, which is again looking at the CPT and HCPCS codes, we would not have accurate counts at all. So we did reach out to HRSA to ask a clarifying question of, if we can create a crosswalk to look at different structured data, and then crosswalk that to the CPT HCPCS codes, and essentially report what's actually done. So we use CVX codes kind of in the back end to allow that data to be captured. So this is a perfect example of, Table 6A is looking at these codes, and we can't change that part, but creating a crosswalk and seeing what the health centers are doing themselves, and then creating a crosswalk to accurately represent the patients that have been vaccinated, and clarifying that with HRSA. That's kind of one of the steps that we've done to really be accurate and make sure that our health centers are getting counted for what was done. Again, every health center may be different with this effort, but this is something that we noticed within our network, and we wanted to try to meet the needs of the workflows our clinical health centers were utilizing, and then making sure counts were accurate. Not only with COVID-19, but in general, if there was ever a point where we needed to clarify anything when it comes to capturing the specific data in our specific workflows, the HRSA website has a great, feedback, email and contact that, we've reached out to in the past for a lot of different things. But I think the main point with this COVID-19, and generally speaking, is data translation is different for everyone, and just trying to understand the workflow and seeing how we can implement that to what UDS wants is an important step in kind of reviewing everything. Kind of staying along the lines with COVID-19, so Telehealth Impact. So last year in 2020, there was a crosswalk that was released that kind of mentioned the telehealth impact of UDS clinical measures. So based off of the pandemic happening last year, they kind of went over what counts and what doesn't count as telehealth. So we review the denominator criteria and, what our UDS universe, as we call it, consists of. And then we adjust logic as needed for those that allow or do not allow telehealth visits. So that's kind of our workflow when it comes to reviewing all the telehealth updates. This picture here is the actual crosswalk that HRSA provides. This is also on their website as well. So it's essentially telling you, the clinical measure. It's telling you if you should include patients with telehealth only visits, and then kind of tells you, can the service test or procedure be done by telehealth? So, we did do a thorough review of all this to make sure that we are, capturing the right type of visits for these patients that are being seen during the reporting year. So like I said, with the pandemic, in-person versus telehealth mattered. So we reviewed this crosswalk, and one of the changes that we noticed for 2021 is right here specifically for the early entry into prenatal care. So as we know, prenatal care patients are really defined by a in-person physical exam here, but they did add the tidbit of if a prenatal care patient was established in the prior year through a comprehensive in-person exam and only seen through telehealth in the current year, that they should be included. So this crosswalk is really, I think, valuable information to kind of see, what counts and what doesn't count. And after we here at Alliance Chicago review everything internally, we then kind of translate that into our reports that we have to make sure that our, patient population we're including consists of the right type of visit. Because as you know, it's pretty varied. A lot of patients come in for telehealth, others don't. So this, again, is another piece of important information. I did happen to see one, we'll go through it at the end, but I did happen to see one chat comment come up, and yes, we will definitely share the link for this. It's on the HRSA website, but only send out the information and the recording and all that. We'll make sure we have the link for it. So we kind of went through a lot. We went through kind of tips of what we do. We went through specific updates for 2021. I wanted to take some time just to kind of go over in general resources that that may be specific to what we have and general resources. So the HRSA website is always going to be a great resource. They have the manual, any kind of specific information, webinars. They have a lot of support on that website, as well as contact information if any questions come up. So I always tell folks that this is a good resource to keep handy. We have the electronic clinical quality measures, the ECQM website. When you go to the manual and you find out, what measure number it is, going to that ECQM website really breaks down the data specifications. So that's another view that one can have, very data oriented. And then we have our Alliance Chicago Community Loop. So for those that are registered and have access to that, we have a lot of different types of wraparound support present on our website. So just to kind of go through a few, we have a UDS clinical guidance document. And again, that is specific. This document is specific for like Athena practice screenshots and all, but it can definitely be used for other platforms. It's just, the screenshots are very specific to Athena practice. But that kind of goes to the table 6B and 7, only those clinical measures, and it kind of goes through workflows and where things are documented in Athena practice. We've gotten feedback from our health centers that it's been very useful. So we did come up with this, all-inclusive document that kind of goes through Athena practice. We have the data request forms I was talking about that the data team uses to kind of create their reports. It's kind of the translation of the UDS logic and all. We also put those on our community loop that ends up being like the source of truth for these reports, and health centers have access to those as well. We have webinars, so any kind of wraparound support we've done in previous years and this year as well. We put kind of all those recordings and information on the loop as well. So we do have a nice little collection of a lot of UDS documents and recordings under our data and reporting section. And so I find that that's a very helpful thing for our health centers to utilize, to kind of have a one-stop shop where you can kind of come and find resources that may be pertinent to you. Finally, our platform we use here is called ServiceNow, but any kind of help desk platform, We do have a specific category for UDS reporting. So if there's any questions that come up with, questions on a measure, question on a report, any kind of workflow questions, we are able to kind of parse that out and help out those health centers that need anything. So these are kind of the main resources that are, available right now. Everyone, again, has different ways of disseminating that information, but I just wanted to share resources that are available as of now. In terms of, continuing on the wraparound support, so today was kind of specific to clinical workflows and data. There is a webinar that's going to be coming up on Friday, October 22nd, between 11 and 12 p.m. Central. This is going to provide a general overview of UDS 2021. And it is going to be kind of UDS 101 and, a question and answer section. So we will also send out the registration link for that, but I have it in these slides as well. But definitely stay tuned. We have this webinar coming up next. And then with our UDS 2021 kind of series in the future weeks, stay tuned on any communication for other specific webinars. We're trying to do different webinars with different lens and different teams. So stay tuned for, ones in the future. But I think I'm done yapping, but I do have a section here. Angela, I don't know if there was anything that came up in the chat or if you or anyone that has specific questions, I can use the time that's left to go over anything that I may be able to help with.
Thank you so much, Tina. This was a great overview. I don't see any specific questions about the content you shared in the chat, but would love to open up these, the remainder of our time together for any questions that people would like to unmute themselves and ask any, or if you prefer to put it in the chat, we are here to try and help answer.
Thanks, Stephanie. I just wanted to read something just in case someone didn't see it in the chat. For Health Choice Network Health Centers on this webinar, Health Choice Network will be hosting interview-specific related reporting webinars for UDS. So just wanted to call that out. And then I think I already answered the crosswalk that will be shared. So yeah, I just wanted to call those things out in the chat in case someone didn't see those.
Okay, well, I'm not seeing any additional questions coming up in the chat, and I don't think we're hearing from anyone. So we will end the webinar so you all can have some time back in your schedules. And please know that we are here through Alliance Chicago, Health Choice Network, and the Illinois Primary Healthcare Association to help answer your UDS-related questions. As Tina noted and mentioned, thanks so much. We do have our next webinar on this topic on Friday, and it will cover UDS on a sort of 101 level and highlight 2021 changes, and also be a time for you to ask any questions that you may have as you're diving into your UDS reporting for this year. As we develop dates and content for additional webinars between now and February, when the UDS reports are due, please stay tuned. We will be communicating that out through the usual Alliance Chicago, Health Choice Network, and IPHCA channels. So thanks so much, everyone. We will send out and make the recording available shortly. Have a great day and a great rest of your week.
Bye, everyone. Thank you.